CataractCoach.com, podcast series, episode number 91, with Dr. Nicole Fram, surgical approach to conquering tough cases and a passion for teaching these new techniques. Welcome back to our Cataract Coach podcast. And today, I got a very special guest. Someone I've known, since she was a resident and still know her now. She's a colleague here in Los Angeles, and I'd love to send her all those terrible nightmare cases that none of us actually want to do. Nicole Fram, welcome to our podcast.
Thank you, Uday. I'm so proud of what you're doing. I think it's so meaningful to the ophthalmology community. And yes, I've known you since I was a first-year resident when you rolled up at Will's Eye as visiting professor in your pinstripe suit and were just like wowed us with phagodynamics and premium lenses. And I was like, we never talk about these things.
I know that was October 2005.
Crazy. Yeah. And then I was tasked with taking you out to lunch. So, of course, I picked Morimoto. So we had to take you out to a good lunch.
Dude, Morimoto is fantastic.
Yeah. So, yeah. And here we are now. So
I'd have been even happy with a Philly cheesesteak. It's all good stuff.
Right. But I couldn't do that with you. I mean, you were super fancy back then.
I know what I got old. It's been 20 years. Oh my goodness. I mean, so at the time I was probably 35 years old. Eesh. I was barely shaven at the time.
Yeah. Well, look at you now.
Well, hey, even better, look at you now. You've just taken over. I am so impressed with the work that you do. If people don't know, in Los Angeles, we've got a lot of great ophthalmologists. Nicole's here. I'm here. You're almost a stone's throw. I could probably throw a rock and hit your clinic from my clinic. And people are like, isn't there a lot of competition, Ellie? I said, there's like zero competition. We're all like partners. We're all colleagues here.
Well, yeah. I mean, I've been able to benefit from mentors, and you're included in that list. Sam Maskett, as you know, who taught you how to do cataract surgery also, was the founding partner of our practice. And I literally did like a 13-year apprenticeship with him.
Wow.
And, we are known for doing, easy cases and some complex cases. And, it's a privilege to do this for people. And it's a privilege to help colleagues. And we don't have that competition with each other because we're all partners, in the same surgery center together, but we all back each other up and we look out for each other. And so when someone's in trouble and they need another set of eyes, I'm happy to be there to help out. We all get in trouble during surgery. Right.
And in fact, that's very true. I'm reminded of when you say that. I'm reminded of a case that I had where I couldn't figure it out. I just couldn't figure out what was going on with the patient. So I said, you know what? Listen, I told the patient very honestly, I'm just not exactly sure what's happening here. I just don't know. And I've tried my best to figure it out, and I really can't. So there's another few people I trust. And you know what? You need to go see Nicole Fram. I'll send her all your records. And she's got like a different take than me. She's younger than me. She's smarter than me too. And
I don't think I'm younger.
Oh, we figured it out.
It's just
you figured it out. Well, we figured it out together.
Right. No, I mean, but I think that, there's so much of what we do that sometimes, if I see a patient and they have trouble after surgery, I kind of pull away because I'm like, no, everybody else is happy,
Right.
But if someone else sends me a patient that's unhappy, I'm leaning in. And so it's instinct to kind of do those things. And so what I try and do with different colleagues in the community is say, let's lean into those patients and figure out, is it an IOL exchange they need? Is it LASIK that they need? Is it just hand holding that they need? What is it that they need to kind of be happier, not happy. Sam Maskett always says there's no such thing as a happy patient in Los Angeles. But be happier with the outcome and to support them. And I always, I say anyone who is offended by a second opinion is a very insecure doctor. And, I think that we all need second opinions and help when we're in the weeds and we can't see what's maybe right in front of us.
Yeah, those are very important lessons. In fact, so Sam Maskett did teach me when I was a resident in like 99, maybe even January 2000. I was the last resident he taught. I sometimes think it's because I was like the best, and sometimes I think it's because like I broke him and he couldn't take it anymore. But he was just such an incredible mentor. blew my mind because as you know, in LA, UCLA, I'll give you an insight here. There are a lot of full-time faculty, but there are also some part-time kind of outside faculty who do private practice and come volunteer their time essentially to teach the young residents. And he brought a fresh perspective that was just amazing to me. And he changed my life for sure. And he was on our podcast, his CataractCoach podcast. He was one of my very first guests.
Right.
And he just had a very different outlook. So, wow, what a fortunate thing that you've been you got to be his trainee or mentee for 13 years.
Yeah. Yeah. No, I mean, I still call him every day and I still talk about cases with him, and he has that institutional knowledge that you can't get enough of. I knew there's only one Sam Maskett, but I just wanted to be next to him and be a sponge. And part of that, to the trainees out there or to the young associates, if you're with someone who is a mentor or you have a senior partner, don't be afraid to ask a stupid question, because I sure as hell wasn't. And your ego cannot get in the way of learning. And what I see a lot of trainees do, we have a fellowship through the Maskett Foundation, is that they don't want to ask because they don't want to look stupid. And that's actually the most dangerous thing you can do as a young surgeon, or even as a mid surgeon, is that it's okay to say, I don't know the answer to that. I need help with this. I never learned that. I remember I said to Sam, I came out of Wills, I went to UCSF for fellowship, and I said, I don't know how to do an LRI. And he was like, I don't understand. You came from top programs and you don't. I said, can we get past this? I said, I have your nomogram. I have the Donenfeld nomogram. I have Nickerman nomogram. I researched this. Let's talk about it. And so, I think that you just have to be in a position where you're not afraid to say, I don't know. And you can learn so much more.
I think, yeah, that's a great point. The only dumb question is the question you didn't ask.
Right. Right. And it's, so what if someone thinks you should have known that? Okay, well, now you know it. Right.
Well, I always tell, if I do ask a question that I feel a little dumb after, I just say, listen, when I was a baby, I was dropped on my head a lot, so it's not my fault.
Yeah. Well, I don't have an excuse.
But no, those are actually really great points. And so tell me, you have a fellowship now. That's an amazing thing, because people ask me all the time, hey, CataractCoach, do you have a fellowship? Can I come train you? I say, I don't have a fellowship.
Yeah.
But I know someone who does.
Yeah. Well, so what happened?
Fellowship.
Yeah. So this is our third year of the clinical fellowship. And basically, we have a foundation called the Maskett Foundation, which has three purposes: to take care of the uninsured or underinsured, and to educate fellow physicians and contribute to clinical research. And through the Maskett Foundation, which is a nonprofit, we fund a fellowship. And the fellowship is designed to teach complex IOL decision-making. So anterior segment, complex decision-making, complex surgery, IOL exchange, every fixation technique you can think of, so that you can think on your feet, number one, if things go awry, and that you can also take care of a very unique patient population that needs this specialized care. And so it's an incredible thing to be able to, I always feel privileged that I got all this knowledge from Sam. I feel like I have an obligation to pass it on. I can't just hold on to it. That's super selfish, right? So this fellowship is everything, because when you see them be able to, from everything from dealing with an unhappy cataract patient to doing Yamani, to doing scleral fixation, iris suturing, artificial iris, IOL exchange, but also learning advanced premium IOL technique, what formulas to use, what different small eye, long eye, post-LASIK calculations, RK calculations, and all the premium lenses that should go along with that, light adjustable lens, all of that, has been a real privilege to be able to train this next generation to not just be average, but to be able to take care of whatever their problems are and whatever problems happen in the community.
That's all. Now, is the fellowship 13 years like you did, or is it just 1 year?
So it's just 1 year. But
Okay.
I'm a mentor for life. Like our first fellow, Marissa Schoen, joined Brandon Ayers and Rich Tipperman.
Oh, wow.
And so I text her like every day, like, come to my practice. And she's like, no, you come here, So that's Marissa, who hit the gate running. I mean, she was just like ready to go right from the start. And then our second fellow, Tiffany Shrews, just joined our practice. So that was a bonus. And she's the nicest person and the best hands. And she's a fantastic person. And then our current fellow, Alice Jang, is going to go to Indiana with her husband. And she is like, I'm like, I don't know if you need me. I mean, she is such a great surgeon. Like, I mean, what is UCSF doing? Because her cataract skills are beyond. But it's just joyful to be able to see them progress and to really, see them as an expert in their field by the end of the fellowship.
Yeah, I think the young generation has an advantage over an old guy like me, or even a almost old gal like you, which is the learning curve is compressed now because things can be seen in video.
Right.
Like I can show you all these complications before you have to experience them. In fact,
you can
the
skip
motivation.
You skip that step.
Right. That's the motivation of cataract coaches. I will compress your learning curve. Let me teach you how to not suffer from a choroidal hemorrhage, a fake wound burn, a ruptured capsule. Let me just teach you all the stuff now. I'll give you all the secrets.
Right. Right. And that's what's genius about it. And that there's such a varied population that you're getting the videos from. So, I mean, one of the most incredible things that I had the privilege of doing when I just joined SAM was that they wanted him to be on the ASCS Film Festival committee. And he didn't have time because he was so busy, but I had time. So I got to review 250 videos from all over the world. Wow. And some of the techniques that I use are from India, Japan, Turkey, all over the world, Brazil, always Brazil, and I'm able to, reflect back on those videos. And I did that for, 3 or 4 years to really hone in on these challenging cases. And that you don't necessarily learn from your attendings in the States. And that's what I love about all the videos that you've brought into CataractCoach, because it's really a varied experience.
Yeah, people are amazed when I tell them I learn far more than I teach.
Yes.
In fact, you were talking about these countries. I was in India in October. I was in Turkey 2 weeks ago. I will be in Brazil in 2 weeks.
You were in Croatia.
This year I've done 21 countries.
You were in London.
It's craziness. But remember, I'm an empty nester. My kids are grown up, so it's a lot easier for me to do this. You still got the young son at home, so it's different.
Yeah.
But I think you're right. We learn so much from our colleagues, and it really does compress that learning curve. And CataractCoach today receives 30 to 50 video submissions a week, and I watch every one of them. I'm that crazy.
Yeah. Well, you always have been.
I know, but the stuff you learn is amazing.
Yeah. Well, you'd spent your whole career doing this with residents, right? Had all this energy. There was no one more committed. And now you're doing it for the entire ophthalmology community. So thank you.
Oh, you're too sweet for saying that. But yeah, it's funny. We all learn together. So, you're talking about masking. One of the most important lessons I learned from Sam was when you see a patient with, let's say, suboptimal outcome of the first eye, some iris atrophy, a little bit of this, sulcus lens, a little bit just to the wound. And he always said, listen, give the first surgeon the benefit of the doubt.
Right.
Because more likely than not, that patient has some bad protoplasm,
right,
some tough anatomy, and that patient will humble you on the second eye.
Oh, yeah. Oh, yeah.
Oh, my God. The best advice ever.
But, it's really interesting that you bring that up, because I just had a patient like that today. And what I say to them is that, obviously, when you see iris damage, that case was tough. You know that something was flopping around and things were going on. And I think that's really sage advice, because I had a patient that had a lens that was, subluxed and had a dead bag, so no fibrosis. And unfortunately, the lens dropped by the time I was able to get to him. Retina doctor took the lens out, and half the iris came out with it, and the cornea was destroyed. And I was like, okay, well, I wish I had been in town, but I can fix it. But then I look at the other eye, and the other eye lens is falling, dead bag in the other eye.
Right.
So I had to tell the patient, you need to have confidence that I can do this. And he said, how do you know the same thing's not going to happen to you that happened to the other doctor? And that's exactly what you said. I said, I'm just going to go slow, and I'm going to do the best I can and learn from what happened with the other doctor. And so in the past, you could look at it and say, well, I don't know what kind of surgeon that is, who did the other eye. But it'll humble you. When you go to that second eye, you better take a bite of that humble pie before you get to surgery. Because if you think you're going to have the same fluidics and the same thing that you always use, it's not going to happen.
Surprise! Exactly.
Right. And after the case, it was the hardest Yamani I ever did. And I had to like contort myself. I had 100 hooks in the eye trying to stabilize the iris. And after the surgery, I said to him, everything went great, but I fully understand what happened with that other surgery.
Yeah. Oh, by the way, sorry for a sidetrack. I met Dr. Yamane at the 75th anniversary of the IOL last weekend, 3 days ago in London. And he said, please, it's not Yamani.
It's Yamane.
He says, it's Yamane.
Okay, good.
Yamane. So now I'm trying because I've been saying it wrong for like years.
I think we all have. So thank you.
So now I'm going to be like Yamane.
Yes. Yamane. Sorry, Dr. Yamane.
But obviously, what a brilliant guy. But yeah, I think these are really great points to figure out. Like, you know what? Yes, the results of patient surgery is half my surgery and my technique and my flip, flop, chip, chop, whatever I do. And half it is your anatomy, your tissue response, and your healing.
Yes.
They go hand in hand.
Absolutely.
Yeah, it's so. Now, patients here on the west side of Los Angeles, and we are in the fancy zip code here. If you don't know, Nicole and I both operate the same surgery center, which is right in the heart of Beverly Hills. And patient expectations, should I say, are quite high. As you were saying earlier, Sam Maskett said, very sage advice. There's no happy patient. They're happy enough. They're happier.
Right. Yeah, I think that you can't really operate on happiness. You have to just operate on the patient, and you do the best you can. And it's really something that you develop over time to realize that your worth cannot come from a patient saying that they're happy. Your worth has to be in your integrity, your ethics.
Right.
And did you do the best job you could for that patient? I mean, often I will, look at all my IOL calcs a week before, and then I obsess over them a couple days before. And then even right before the surgery, I'm doing like 3 timeouts to just make sure that I have everything in order. I have my CTs up. I'm just making sure that everything's the way I want it to be. And when I have those timeouts in place and I have my OCD in place, I know that I've done the best I can. But then when I go out to the bay where they're pre-oping, I then see them, and often I'll mark the eye if I'm doing a toric, old school, but I will do that in case all technology fails. And I'll say to them, do you have any questions or concerns? And I think it's really helped. And 9 times out of 10, they're like, no. But it helps to confirm what you're doing, why you're doing it right before. And a lot of high volume surgeons are skipping that step. And they're skipping the step because time is money and money is time, and let's go. But I think you'll catch things and you'll keep yourself from getting in big trouble by doing that simple timeout before they've received anesthesia, obviously, to just say to them, do you have any questions or concerns? Today we're doing a trifocal lens. You'll see at all distances. When you drive at night, you may see some rings and halos. And if you have that, I'll help you. And so, but it really has helped me in dealing with this patient population to just give them that extra bit. Obviously the day after surgery and reinforcing things, but doing that special timeout, because then they say, I didn't even see the surgeon. That's a rough statement.
Right. Yeah. No, I totally get it. Now, how do you deal with certain situations? Like you brought up an example of a trifocal, which is great, which certainly gives all the range. But I mean, the number of photons entering the eye is the same. And if you devote all the photons to one range, or you split the photons up into 3 ranges, you get a little bit different visual quality.
Right.
So how do you deal with the patient who gets this and, like, despite you explaining everything ahead of time and showing them a video and saying about the nighttime, the glare in hand, and they're still not happy? How do you deal with that?
Well, what's helped me is in my pre-op exam, I say, I think we've all become a little bit more comfortable taking out these lenses.
Right.
And I think if you're going to put it in, you better know how to take it out or have a best friend that will. Okay. And what I always say to the patient is that my commitment to you is that 1 to 3% of patients will not be able to tolerate the rings around lights and glare.
Yeah.
If you fall into that category, I will help you. We'll do a different strategy. We'll do mini monovision. But then I flip it and I say 97% like it, provided that you have a perfect cornea, a perfect retina, and all those other things. So I have felt that the pressure on my trifocal rate and EDOF rate is much higher since I've been able to have that conversation with patients ahead of time.
Right.
And because I do complex surgery and take things out anywhere from, 2 months out to 10 years out and have strategies to know how to do that, my anxiety, and I'm not saying I'm perfect, but I'm saying that I will stop if I think that I can't get the lens out safely and they're going to need a Yamane procedure. I tell them if it's too hard, I'm going to stop. But if it's not, then this is the strategy we're going to go with. And so the key for me is to maintain that commitment to the patient.
Right.
To make sure they know that I'm not just going to bail on you. I mean, I have so many patients that are orphaned. When you send me a patient, you send me an email with the patient CC'd, you keep yourself connected to the patient.
Right.
That's so important. A lot of people, they just find their way to me and they say, my doctor said I would go blind if I, took it out. And and maybe, and what I say to them is maybe if they did it, but we're going to try and help you. Like, I don't know, but I think that has helped me a lot with trying to take on new technology, being an early adopter and working with more presbyopia correction and different types of lenses. It's helped me to say, I'm going to help you if you're having a problem and have a strategy ahead of time that you're going to do.
No, that is great advice. In fact, I like you saying that if you're going to put the lens in rare circumstances, let's say 1% of the time, you should be prepared to take the lens out. And on CataractCoach, we've got great videos already of how to do IOL exchange. And in fact, the day after this podcast airs, we've got a video of you showing how to take out a multifocal lens, even in the presence of a prior YAG capsulotomy. Right. So we're going to have that video as the video of the CataractCoach Day, featuring it, the day after this podcast. But that's a great point. You got to be able to do that. I tell patients there's a 1% chance we'll go back, we'll have to do an IOL exchange, take the lens out. But if you complain a lot incessantly, there's also a 1% chance we're going to go back to the operating room. I'm going to put the cataract back in. Well, joking. If there's a patient listening, we're joking.
But the sad part is when it's my patient or a referral and they say, I wish I'd never done this. That like hurts my heart, and I think we don't hear it often, but I think it is important to understand that there's a certain amount of patients that aren't going to adapt well to cataract surgery, whether it's because of dysphotopsia, which is obviously an area of research in our office, or it's just that they don't have the range that they had before. They had mixed astigmatism and they weren't a candidate for a trifocal or monovision. So that's the other patient population that, you're so sad hearing that, but you need to lean into them and say, I wish I could put your cataract back. I can't do that. What can we do to make your life a little bit better? And not forgetting to give them like a pair of distance glasses, while we're waiting to get them off of drops or waiting to kind of do an enhancement, give them something so they can function, right? So I think that's really key. I think John Burdall brought that up just recently at AAO, and I thought it was such a good, like, okay, you missed your target or the toric rotated or something happened. Well, give them some help while they're waiting. Right. Don't just say, oh, you had a problem. I think that's like a huge, simple fine-tuning point that you can do before you need to do any other interventions.
Yeah, you also had a great point of lean into these patients who are having issues. Don't shy away from them. Don't just say, return to clinic like 1 year. See ya.
Yeah.
You got to embrace the issues. You're going to be there be there for the patient. Don't abandon the patient.
Right. And it's hard, it's hard to do when maybe it's not someone you want to hang out with, right? I mean, it's hard, but that's the practice of medicine. And that's, we were talking, I was talking to some friends about, we're trained to have, if there's an issue during surgery, we're trained to, put ourselves back together and go on to the next case, right? So you finish that case, and we're trained to do that, to be robotic in that way, to finish our day. What we're not trained to do is to deal with things after, and to deal with these psychological issues that are happening after in the clinic. We don't have proper training on how to deal with that. And I think, the more you can talk to your mentors, like, what's your spiel? Like, how do you, for dysphotopsia, we say, are you annoyed or are you debilitated?
Right? Important differentiation.
Important, very important. So, and sometimes they're like, I'm annoyed and debilitated. I'm like, okay, but debilitated. So we need to help you, because just because, you have a hammer, everyone's not a nail. And, the other thing is, if they have a trifocal and they're unhappy, everyone talks about this, put that minus 275 up in front of their face. You probably taught me that, to show them, what does it mean to lose your vision?
Right.
I know that this is my enemy, my reading glasses. So I think it's really important to show them that before you're real quick to say, oh, multifocal or diffractive dysphotopsia, let's get this lens out.
Right. I found that in my patients who come to me for a second opinion, who are not happy with the trifocal lens, the most common are the ones who are 50-ish years old, no cataracts, plano presbyopes,
right,
who exchanged a clear, beautiful 20/20 crystalline lens for trifocal, and they're like, yeah, I could technically read the letters, but this is a significant drop in the quality.
Right. Well, I mean, I always tell patients in that age range that will come to me for a second opinion, if I thought everyone should get diffractive technology or trifocal, I would have it right now.
Right.
And all my friends would. So, we really have to have something that is going on where the risk-benefit ratio is there.
Right. And it's also important, the before versus after, the delta. It's easy for plastic surgeons to show you the before and after. For us, as refractive or cataract surgeons, it's a little bit harder. But I think the patients who, if you start off with bilateral 20 out of 200 cataracts, I promise you will love that trifocal lens, even if you have a diopter residual still.
Right. Right. Give me a 5+ PSC.
Right, exactly.
It does matter where you started from. But, there are a lot of strategies, in that patient population. The younger patient population is more perceptive, and I think we have to be careful with them. So, sometimes light adjustable lens, mini monovision is a little safer than a trifocal approach. But if they want, mini monovision is 80/20. It is not 100% out of glasses, so it's 80% out of glasses, 20% you're going to wear them. So, if someone wants it all, and I show them the simulation, and this is not a 50-year-old, but this is someone with cataracts, and I show them the simulation and they don't have a visceral response to the glare and halo on the simulation, then I've said, listen, I'll make that commitment to you. Let's see how it goes for you.
I like that. Yeah, you got it custom tailored. I mean, I would be the worst patient. I'm -2 spherical.
Oh, you're my favorite.
And I love to take them off and just to function all day, and my near vision is spectacular.
Yes,
I'd be the guy who would say, I said, Sam, do me a favor. I said, don't touch my near vision. It's perfect. Just fix my distance vision.
Yeah. Wait. Yeah. That's my favorite. That's so amazing. So what I've done with those people is do you want to do near or distance? My distance is fine. I just need my near. I'm like, okay, but you have to choose, if they're not a candidate. And then if they keep doing that, I'm like, I'm going to see you in a year. Cause I'm like, I can't, I did it every which way. I can't keep doing it. I just stop. I'm just I'm out.
Well, it's one of the tough things. I mean, ophthalmology is such a weird little, specialty that we're in, and how your average patient who walks in your clinic hardly knows the difference between glaucoma and cataract, let alone you throw in words like astigmatism, or as the patient say, I got 2 stigmatisms, one in each eye. I'm like, okay.
Right. Well, but that's our job, right? The education part of it. I don't delegate the education. I do it myself. Sure, videos can help. but I sit in there with my little iPad and the Rendia like markup screen, and I try and, show them this is the cornea, this is the lens, this is the retina, this is why they are a candidate, why you're not. And it may take me, 5 minutes longer, but they can never say that I never told them. They can never say, when they know that I went through all that I never told them. They can say I didn't understand it and I didn't catch it. And then we do a telemed later, or someone from my staff says it again. But I really want them to hear it from me, because I get upset with myself when I'm not the person that I thought I was in that room with them. That if I know that I consent them and I talked about everything, it's fine to have reinforcement. It's fine to send videos, but you have to be the one to tell them so that they can have the proper expectation of the journey.
Right. Now, how do you say no to a patient? Because I do this not too often, but every once in a while, I'll have a patient who comes in for surgery. And if it's a mild cataract, it's very easy to say, listen, if it's not broken, don't fix it. You're fine. Like you said, you can't decide what you want now. I'll see you in a year. Right. But there are other patients who are like, yeah, you for sure need cataract surgery, but for whatever reason, I still want to do your surgery.
Are those the ones you're sending to me?
I actually do. I got to admit. If a patient sees me, I had one recently where there was a sticky note on the patient thing. The staff, or the front desk staff said, this patient yelled at me at the front desk.
Yeah.
Now I'm afraid to touch that patient.
Yeah. Well,
you yell at the front desk staff, who are the sweetest people.
Right. But here's the thing. Okay. So you never know what happened to that patient before they came in your office. You don't know if someone passed away. You don't know what's going on with them. So I tell my staff, we don't use the crazy word. We call them special.
Okay.
It's better. And we also talk about the fact that you have to meet them where they are. Now, there are boundaries. Like, I don't like it when people are rude to my staff and then nice to me.
Right.
And then I will actually, after I establish relationship with them, I'll say, now I understand you had an issue with my staff. I didn't have an issue. Oh, that's so interesting, because there was an issue that they told me about that they felt like maybe you didn't feel you were getting the best possible care. No, I never felt that way. And so either they're totally unaware or they're gaming the system, but at least they know in that moment that all we're trying to do is give the best care. And we expect that we treat each other with kindness and respect. And so I just had to do this the other day with a patient, because she complained at the surgery center. She complained here in the office. Everybody's putting those Post-its everywhere. But with me, she was a total angel. So I had to figure this out so I could continue to care for her. It's hard. If you don't like conflict, you don't want to do that. But you can do it in a loving way and say, I don't know, maybe something happened. Is there anything I can help you with? Did you have an experience that wasn't pleasant for you? And when you do that, it sets your boundary that we treat each other with kindness and respect so that they understand the rules, right?
That makes sense. I like that. I like that a lot, actually.
You can take that one with you.
Do I do? Yeah, that's a great.
I'm going to send that patient right back to you.
Listen, I'm happy to see anyone. Don't worry. We're happy to do that. Again, that's the thing with the community. Patients are often surprised when they come in for a second or third or fourth opinion. Do you know these other doctors? I said, yeah, I know them all. They're all good people.
Right.
I said, as you as a patient, just got to find the one surgeon you connect with and just go with that. And if it's me, great. If it's someone else, great. Just enjoy. I don't. Honestly, I should work less, not more. Well,
yeah. I mean, you're cataract coach.
No, yeah, that and $5 gets me a Starbucks any day of the week. Now, another thing you talked about with your tough cases, which I really liked, you presented this in New York as well, is the kind of slow and steady approach. And I remember in the New York case, at OSN New York, we were there, you had a beautiful case, you're very complicated, you're putting on, and you had like even a traction suture, the limbus. And someone in the audience said, well, why'd you put a traction suture? And you're like, because I just want to take my time. I want the eye centered. I just want to have no grief. And it takes me an extra 30 seconds. That's okay.
Right. My block was incomplete and I had to have a nice centered video. But yeah, no, I will go to every effort to make the patient comfortable so I can take my time during surgery. Absolutely. So subtenon, if the case starts getting complicated, subtenons block. Doing that from the start to make sure if I'm doing an IOL exchange or complex case, this whole idea of doing these things under topical is very attractive, but it doesn't necessarily give you the time you need or the cooperation.
Yeah, why suffer?
And then the traction suture allows you, I don't have an assistant all the time. Sometimes when the fellow's with me, but if I don't have an assistant, there are certain anatomical features like a prominent brow or a lot of filler in the cheek, or
we get that a lot in LA,
or a big nose, that I have to move the eye around to get access to certain areas, and I don't have that third hand, and so I'll use the traction suture for that. So that was a 6.0 silk.
Yeah. I also noticed I have a video of yours coming up again tomorrow, which is this IOL exchange. You even stain the side port blade with fluorescein when you make the Paris.
Yeah, well, that's all mask it. You can't take credit for everything, but staining the side port, not with a lot, is just enough to be able to see where you can go in and out of your Paris. You can also mark it, with a marking pen, but it's a nice technique.
Yeah, it makes it easy.
Yeah,
I just think, that's brilliant.
Yeah.
But
yeah. So
those tough cases you make look easy, but we should tell you that the video I'm going to show tomorrow is edited to like 3-4 minutes, but this is not a 3-4 minute case.
No, I can give you the 30-minute version.
No, we like edit. CataractCoach, the young generation does not have time. You cannot show the 30-minute video.
They don't have time. But no, I think that, when you're taking on these challenging cases, so let's say, you're finished listening to this podcast and you're like, I want to be able to handle all my problems and the community's problems. You need to schedule them properly. You need to have the proper anesthesia. So at first, schedule them for 2 hours, at the end of your day, and have the proper anesthesia. If you've never done the case before and the patient's kind of squirrely, schedule general, do an LMA if your surgery center allows it. Give yourself the time. I make these buckets for the staff because we have different nurses, right? So I'll make the Plan A bucket and the Plan B bucket and the Plan C bucket.
What do you mean?
Plan A is, let's say I'm taking a lens out and it's an open capsule and I want to do optic capture. So in that bucket, I have everything I need for that surgery. So I have the vitrector, if I need it. I have, the side port blades I want. I have the capsule retractors. You'll see that in the video. So I use capsule retractors to preserve the zonules when the capsule's open. And then my Plan B is my Yamane, right? My Plan B, I have the 3-piece lens of my choice. I have my side port blades. I have everything I need there, iris hooks, whatever I need to get access and to visualize things. And then my Plan C is if I'm using Gore-Tex and I have my Gore-Tex pulled, I have the Tecile in case I want to use it. I have my MVR blade. I have the cautery. So I have everything that I need so that there's never a point where I'm shifting from Plan A to Plan C because I know one thing won't work, where I have to ask the nurse to go out of the room and go get this and go get that. I have it all set up for them. The whole surgery center is relaxed because they know no matter what, it's all set up. Just like if you're doing a pseudo-exfoliation cataract. I never assume that I don't know if it's because I'm Jewish. I don't know. I never assume everything's going to go well. And I always have the contingency plan. So I'll have my capsule retractors. I'll have the CTR injector. I'll have the Ahmed segments. I'll have the Gore-Tex all pulled so that they're not searching around when I need these things in real time.
That's smart. It's kind of right there. So do you have also little contingency kits then made like for routine cases? Like, okay, in case I have like zonular weakness, I have a CTR here, or capsule breaks, I have the vitrectomy set up. Or
they're all just sitting there waiting, so no one's running around. I'll make one for you because you're in the same surgery center.
Yeah, even better is make a list.
Yeah,
and we can feature it on CataractCoach. That's even better.
Yeah. No, we
give
can
me
do
just
that.
a list, and then we can. My goal is to share the knowledge with everyone. I democratize all anterior segment surgery knowledge for free.
Right. Well, I think that cuts down, especially if you're at like the VA or, you're somewhere at a county hospital or you're with, you're in a new surgery center. The more you are prepared, the more relaxed you're going to feel. Right. So, it's hard to take on these cases, and it's hard to be in a situation where you weren't expecting something. You get that like wave over your whole body. You're like, oh my God, this is happening. But if you have the staff prepared, or if you're prepared, or at least know where to find it ahead of time, then less of the anxiety is there.
Yeah, no, for sure. That's the funny thing with operating. I mean, no matter how many cases you do, no matter how many decades it's been, you're doing a case, you see something that just like strikes you like, oh my gosh, that red reflex looked really clear, and all of a sudden you get this catecholamine release into your circulatory system. Your heart starts pounding.
Right.
It's like instant. You can't stop it.
Right. And then you pull the phaco out. No, don't pull the phaco out. But that's the other thing that we talk about on our podcast with Liz Yu and I, called Quicksand Chronicles, is that how are you regulating yourself in that moment when you feel like you're dying, and what do you say to yourself? How do you calm yourself down? Whatever, biofeedback, breathing, remembering that you know how to do this, to allow you to get through that moment. And sometimes the most heroic thing to do in that moment is stop.
Right. Well, stabilize the situation, as you said earlier. Don't pull out.
Yeah.
Inject viscoelastic, stabilize things. Then you can come out, and then give yourself a minute or two. Figure it out a little bit. Take a break.
Right. And be kind to the staff.
Yes, for sure.
They're going to help you get through it. Right. So,
for sure.
So all those things. But I mean, I get referrals from all over LA, and the people that, just stopped because it was either out of their skill set or emotionally it was too hard are the people that I respect the most, because they had the insight and they had the emotional intelligence to say, I'm not the best person right now. Mm-hmm. And I need to do this another day, or refer. And I have so much respect for people that do that. I've done it myself. And I have respect for myself when I do that, because it's not an easy thing to do, to say, I'm not going to put a lens in you. That we're not going to do that today. The capsule was not strong enough to hold a lens.
And that's okay. A stepwise approach is actually okay. I'm with you there.
Right.
Absolutely. I had a guy today, recently, I did his IOL surgery. He had a traumatic cataract, normal volume support, but he had a chronic mydriasis for like 20 years.
Mm-hmm.
And I said to him, what should we do? Should we just do the cataract, or can I also do your pupiloplasty? And we decided, you know what? Let's do the cataract first. He says, I've had the traumatic mydriasis for 20 years. I'm kind of used to it. Do the cataract first. Let that set in for 3 months. Let the capsule contract. Mm-hmm. Give me a deeper AC. Give a little more room. And if we need to, we can come back in 3 months and then do the pupiloplasty.
Right. And that's, Mask had always liked to wait at least he would do the cataract and then wait 6 weeks and then do the pupiloplasty. And then there's, Mike Snyder and Ike Ahmed and Brandon Ayers. I go back and forth. I will often tell a patient, if it's a traumatic cataract with a lot of zonulopathy, I'm going to see how I feel. I'm going to see if I still have it in me to do the pupiloplasty cerclage, or I might stop. So we'll find out, and I'm very honest with them. I'm like, sometimes you have it in you, and because cerclage is the hardest thing we do.
Yeah, I like the pupiloplasty instead. The Agarwal 4th row, just a couple of that's way better.
But it's not round, dude.
It's round enough. Especially if they got brown eyes. It's easy.
Yeah. Right. No, you're right. I love the Agarwals.
But yeah, in fact, good point. There are a lot of different techniques. There are a lot of ways to skin the cat. So whatever approach is best in your hand. People always say, well, do I have to learn chop and vertical chop and horizontal? Yes, you don't have to do anything. But my advice is learn all the techniques, find your favorite. If you like in basketball, if you're playing one-on-one and you like layups, okay, you do layups. If you like 3-point shots, whatever your sweet thing is, just do that.
Right, but what I love about what you show is that you make it accessible, right? And that's what I try and do with my videos on IOL Exchange, and when I present, my quicksands that I've gone through, because I do that. I'm not trying to show off and show people how great I am. I'm trying to make it accessible so that when they're in trouble or when they take on that case, they can end the case with a successful outcome.
Right.
I want to tell the secrets. I want to tell what's, in between the edits, right? Because that way they can actually do the surgery. When we show these highly edited videos and it looks like everything's great, well, what happened the step before that didn't work? Right. So I think that's, something that I've really tried to do in my career. And it was a vulnerable position to be in early on in my career, to show, a lot of my complications. But I think it showed how dedicated, our generation is to really helping people be better surgeons.
Oh, that's absolutely right. I mean, it's fantastic advice here.
Yeah.
But yeah, we continue obviously to keep learning, getting better. And I got to ask you about, in the video we're showing tomorrow, you do a beautiful limited pars plana antivitrectomy. Now, is doing a pars plana approach for an antivitrectomy, is that within the realm of all cataract surgeons?
So I think so. But I think you need to have a mentor and practice. And there are skills training courses that Lisa Arbusser and Steve Charles put on at ASCS and AAO. I think it's important to understand the anatomy and stay where you belong, right? And to understand the fluidics and when to cut first and when to irrigation and then aspiration and then cut is appropriate. So if you're going to take it on, then you need to know how to do it. I think that, David Chang and all these colleagues showed us very early on that it's much easier to get vitreous when you go from a pars plana approach than when you're hydrating at a limbal approach. But if limbal approach is what you feel comfortable with, then you stay in that realm. But I really do believe that when you're suturing to the sclera or you're doing intrascleral haptic fixation, that it's really important to learn a pars plana assisted vitrectomy or have a retina colleague with you that can do a vitrectomy. Because, I worry about three things after these crazy cases that we do. I worry about the retina, retinal tear, retinal detachment. I worry about glaucoma, intraocular pressure, and I worry about the cornea. And so I'm always doing cell counts before. I'm always doing RNFL and visual field when I can before. And I'm always imaging the retina to see if there are any risk factors ahead of time that I may need retina to do a real full vitrectomy before I do my limited pars plana assisted anterior vitrectomy, or I'm okay on my own. And then I make sure that they see the retina doctor at least, 2 to 3 weeks after surgery, in addition to me looking, so that they have a relationship with someone in the event that something happens. Because I tell them I'm going into places that I don't necessarily belong, right? These are off-label uses of these lenses. So, but I do think that it's in the realm of the anterior segment surgeon. I think that we need to add a layer to it, that we, in the middle segment surgery course that we do with Christos Infantidis and Siddhar Hanish, we need to add a layer of inspecting after, whether it's you putting a Charlie lens on and doing scleral depression or using a biome, whatever it is. I think if you're going to do a pars plana assisted antivitrectomy, you should inspect after.
Check for anterior side breaks for sure. Yeah.
So that's something that I wasn't doing. It was like, don't ask, don't tell. Like, it's not there if I don't look. But it's something that that I'm pushing myself to do now, because I think it's important.
No, for sure. Yeah, another great point was that a lot of the videos that we show or you see at the meetings are very highly edited. In fact, on CataractCoach, I started a subcategory. If you go to the actual website, instead of YouTube, go to CataractCoach.com. If you look at the complete list of articles and videos, the one that's called Complete Cataract Cases are all me operating, no one else, only me under that category.
Unedited.
It's completely unedited.
Wow.
First incision to end a case, it's all unedited. You can see the whole thing. You may hit fast forward a lot.
Right.
So he's warning you.
Right.
But you can see the entire case unedited.
I think it's great.
Yeah, it's a neat way of learning. Well, I mean, the challenge, I'll tell you, as a guy who studied the metrics extensively on YouTube, I've got to show something good or exciting within 30 seconds or they're gone.
Right.
On Instagram, I have to show it within 3 seconds. There's got to be action within 3 seconds that gets their attention. Otherwise, swipe and they're gone.
Yeah.
It's so crazy, the world we live in now.
Yeah. Well, I still think, I think CataractCoach is great. I think meetings are great. I love smaller meetings. I love ASCRS to really get into how to become a better surgeon.
No, for sure, for sure. I think we're gonna have fun. Next ASCS is gonna be here in Los Angeles, in our hometown.
Oh yeah, oh yeah. Are you hosting a party or what's going on? Are we going to your
the
house?
best part
You're
is
going to Uday's house.
come. You're welcome. The best part though is every night of the meeting, I get to sleep in my own bed.
Yeah, it is.
There's like a magic in that.
Yeah, it is.
So, and if you're gonna attend the meeting, just be warned. It's not in the fanciest part of LA.
Yeah, but downtown's cool. We can recommend some spots.
Just don't wear anything too fancy.
Right.
but I'm definitely looking forward to it. It's obviously a great learning experience. So
yeah, you can drive 10 minutes and you'll be in the fancy part of LA. So don't worry, people. It's still fun. It'll be great. We'll find some rooftop areas to talk.
The best part of ASCS is, of course, obviously just connecting with colleagues, because now all the education, arguably the best education right now, is available on your phone anywhere on the planet in high def at any time.
Right.
But I think the ability to connect with colleagues, that's really the magic of the meetings.
Well, I think, also we touched on this before. I mean, if you're in an academic center or you're in a multi-specialty group, you have that camaraderie with a lot of different surgeons. When you are in a 1 or 2 person private practice, you don't necessarily have that connection to grand rounds and I just had this tough case and I wanted to bounce it off someone. And going to these meetings, at least for me, has been a space where I can have that relationship with fellow colleagues to kind of be like, I know what you're feeling. We're in it together. I was just there. And it somehow it fills your tank.
Yeah, for sure. And we should congratulate you. You're on track now to become ASCS President in a few years. That's exciting.
Crazy. So crazy. Yeah. Well, I'm honored.
Awesome.
I'm honored to serve. It's incredible. I mean, I grew up at ASCRS. So whether it was being a judge on the film festival to teaching in courses to Quicksand Chronicles and the podcast and being part of Cataract Committee and now, this huge honor, I really believe that it's where you learn how to operate. And so it's a real privilege for me to serve.
Oh, that's awesome. We're incredibly proud of you. You've done amazing things here.
Thank you.
Now to kind of sum this up here at the end, our podcast and CataractCoach leans towards a lot of ophthalmologists in 30s and 40s. Now, we have all ages, even up to people. I've gotten emails from ophthalmologists who are 80 plus years old saying how much they love CataractCoach and the podcast. But in general, I'd say the lion's share is 30s and 40s. Now, what great sage advice do you have to offer now that you're coming on? You're getting
stop it. No, you stop it. You stop it. No, I'm 15 years in. Yeah.
Well, you're at least 20 years after med school, right?
Right. Yes, I am. But no, I think that the biggest piece of advice is to ask for help and to continue pushing yourself. I always try and learn 3 new techniques a year. To continually try to get comfortable in the uncomfortable. And that keeps you stimulated and it keeps you wanting to be better. So that's really what I think drives me is innovation and technology and moving the field forward. And in order to avoid burnout and in order to avoid kind of the monotony of what we do every day is to push yourself to try and do 3 new things, 3 new surgical techniques a year.
That's great advice. Yeah. The continuation of the learning process is so critical. I was giving a lecture overseas recently, and someone asked me back when you were doing your training, I said, just keep in mind, when I did my training, there was no anti-VEGF medication. There was no OCT machine. There was no femtosecond laser. There was no dual shine fluid tomography. There was no lamellar transplantation. There were no good phakic IOLs. You didn't have any trifocal lenses. There were no EUF lenses. Everything I do today,
and you learned,
is self-taught.
Right. And so, and that's why, and I'll bring it all back full circle.
Let's do it.
becoming an early adopter is contingent on learning how to do IOL exchange. If you know how to do IOL exchange of your own patients, of other people's patients, then being an early adopter will allow you to fix any problem with a new technology.
That is key. I like that. Again, with that said, we have got amazing videos on how to do IOL exchange on CataractCoach, how to dissect the lens out of the bag, how to twist and out them, how to cut them in half, how to do whatever you want, Pac-Man them, fold them in the eye. I've got all these videos. You know, we're up to 2,400 videos already. Still a new one every day. And tomorrow we're going to have Nikki Fram's amazing case with a partial anterior vitrectomy. I already watched the video.
Okay.
It's so good. It's so good. And then dissecting the lens out. And then probably the killer move that I loved the most was using a capsule hook as counter traction to support the bag or the remnant of the bag as you dissect the lens out. That, I'm stealing that one.
No, sure. Listen, the other thing is there's a framula in it.
Tell me.
The first thing you see, which is it's a Donnenfeld spatula that is a cannula, and the cannula comes out from the bottom. It allows you to dissect under the capsule and then get the viscoelastic in the right direction.
Oh, interesting. I always used Alan Crandall's technique, the great Alan Crandall, where I'd put a 27 gauge needle on the viscoelastic and then bevel down and just get it under and inject the viscoelastic.
Same idea.
Oh, so cool. Wow. Nicole, I cannot believe we've been chatting for an hour. Unbelievable.
Wow.
I will be sure to make a list of all the important points of this podcast and trying to send you as many special patients.
I listen. I'll do them. But you know,
you're the best.
I really, really love working with you. I'm honored to be on your podcast, and I really, more than that, I love what you're doing for the ophthalmology community.
Oh, it's all fun. And you, again, the same way. We were basically cut from the same cloth. You're just like a newer, better, smarter version.
I don't know about that, but
all right. Thank you again. And remember, all our listeners and our viewers, we've got a new podcast every Sunday on all podcast services, Apple, Amazon, Google, Spotify, you name it, wherever there's a podcast, we're on it. Plus, of course, a new CataractCoach video every day, including tomorrow, where you see Nick Fram doing that tough case we talked about. So until next week, catch you later.